So dear colleagues, at the beginning, I would like to express my thanks to the organizer of this conference, especially to Professor Ines Schaldhout for her kind invitation to be part of this event. And today I will speak something about new treatment for diabetes and obesity. So we know that there is a very clear link between obesity and type 2 diabetes. And until now, we still don't know the exact causes of diabetes, but it is known that the factors, there are a couple of risk factors that ups the risk of developing different type of diabetes mellitus. And especially for type 2 diabetes, this includes the overweight or obesity, that it is especially for those people with BMI of 30 or greater. So in fact, the obesity is believed that is responsible for about 80 to 85% of the risk for developing type 2 diabetes. And this recent study that I show you suggests that obese people are up to 80 times more likely to develop type 2 diabetes in comparison with those with BMI less than 22. In this graph, we can see that the obesity is actually the main driver of type 2 diabetes, especially obesity with BMI more than 30. So we can clearly see that those with BMI more than 35 have more than 90% greater relative risk for development type 2 diabetes in comparison with those with normal body weight and normal BMI. So obesity is associated with multiple morbid conditions, as we really very good know. But for this talk, it's very important that obesity is associated with type 2 diabetes, and this is especially for the female population. It's obesity elevated the risk for developing type 2 diabetes. That's why there is treatment options that are offered as a recommendation from recent recommendation from the ADA, also from AASD, for treatment of obesity in patients with type 2 diabetes. And there are some difference in comparison with the previous recommendations. As we can see, as a treatment options are, of course, as the first line diet, physical activity and behavioral treatment, or non-pharmacological measures for all different stages of obesity. Then the second treatment is pharmacotreatment, which is offered for patients with BMI less than before, 27 up to 29.9 BMI. And finally, metabolic surgery now is recommended for those with BMI more than 30, and formerly it was recommended for patients with BMI more than 35. And what are the goals of this treatment? Like a first is a weight loss for at least 5%, which can be achieved with calorie restriction of 500 to 750 calories per day. Then physical activity 200 to 300 minutes per week. And of course, a very individual approach with aim, with education, and with the support of the patients, and with aim for a long-term maintenance of their eventual weight loss. What are the changes in nutrition, in recommendations regarding nutrition treatment for adults with diabetes and pre-diabetes? We have a new consensus report since 2019, where there are recommendations not just for people with diabetes, but also with pre-diabetes. So what is new since 2013 is that these recommendations are recognized very low carbohydrate diets as a very safe way to lose weight and to control diabetes, especially in those with unstable diabetes. And what is here the new, as I said, this is that this is the point on weight loss in patients that are obese, not just with diabetes, but only with pre-diabetes, because it's only very well known that the weight loss is not just for treatment of diabetes, but also for diabetes prevention. And what are the main recommendations are that there is no, like before, specific recommendations regarding the proportion or percentage of daily intake of carbohydrate, fat, and proteins, but the recommendations are in favoring of healthful eating patterns and eating a food in appropriate portion size. And of course, as I said before, in type 2 diabetes, at least 5% weight loss for some clinical benefits, but like an optimal goal is loss of 15, even more percentage of initial body weight for a better, not just treatment, not just better treatment for type 2 diabetes, but also prevention for cardiovascular complications of the disease. Is there any really evidence that can support that these non-pharmacological measures can prevent or postpone the onset of type 2 diabetes? I will show you this very interesting study, direct study, which was published a couple of years before in Lancet. This was a trial that was comparing the two groups of patients with diabetes, overweight and obese. The first group was treated with best practice care that we know, and the second so-called intervention group, that was group where was offered the restriction of calorie intakes and a restriction to maximum up to 853 calories per day, what is really a significant amount of calorie restricted. But there was a program for support of this patient and education how to reach this and how to maintain this calorie intake for a period of 52 weeks of the duration of this trial. But really the results were quite spectacular, as I can say. So in this intervention group, the weight loss were more than 50 kilos was observed in 24% of patients, and 0 in control group. Then diabetes remission was observed in 46% of patients in intervention group, and in 74% of patients in this group, there was a drug discontinuation. So discontinuation of all medications for type 2 diabetes. And what is also to emphasize, quite important for this study, is that the most benefit of this intervention was seen in group that was able, of patients that were able to lose more than 10 kilograms, and 73% of these patients are in remission of their disease. There is also another study, the Look Ahead study, is a bit older study. This is also an intervention study that was performed in patients with type 2 diabetes, overweight and obese with BMI more than 25. And here the calorie restriction were less. The patients were suggested to take 1,200 to 1,800 kilocalories per day, and with physical activity. And the patients were followed for 8 years. And it was observed that in patients in intervention group, there was a significant reduction in body weight. So as you can see, up to 12 kilograms since the beginning, and also significant change in glycated hemoglobin A1C, so the better control for their diabetes. And this study shows actually that this intensive lifestyle intervention was beneficial not just for metabolic control of diabetes, but also for improving lipid profile, blood pressure, sleep apnea, hepatic steatosis, depression of patients, then less severe of kidney disease and retinopathy, improved quality of life. So a lot of benefits was seen in this group with intensive lifestyle intervention. And what are the medications that are approved by FDA for the treatment of obesity in patients with diabetes? We can see several groups here of phentermine, orlistat, phentermine combination with topiramate, then naltrexone with bupropion. This is all combinations of different kind of treatments for obesity, and we can see that regarding their effectiveness, they can reduce body weight maximum up to 10% of initial body weight. I think so that what is most interesting for us as a diabetologist are the efficacy of treatment that we can give, not just for body weight reduction, but also for treatment of diabetes. And this is the group of GLP-1 receptor agonist. And this is one drug, this is liraglutide of 3 milligrams that is approved by FDA for treatment of obesity in patients with type 2 diabetes. And it can reduce liraglutide body weight for up to 6% of initial body weight. But what is even more important for this drug, for liraglutide of 3 milligrams, is that not that it can reduce body weight in patients with type 2 diabetes, but it can also reduce the diabetes risk in patients with pre-diabetes. So we can see in this from this trial that in patients treated with 3 milligrams liraglutide, time to the onset of diabetes was 2 to 7 times longer than in patients treated with placebo, which shows that these drugs is not just for weight reduction, but also for postpone the onset of type 2 diabetes in patients with pre-diabetes. This is the beneficial effects on body weight in all group of GLP-1 receptor agonist. Maybe the best effects are from semaglutide, and here we can see that with this medication, with semaglutide, the patient can lose 5.6 up to 6.5 kilograms in different trials that examine these drugs. But the whole group of GLP-1 receptor agonists, beside their anti-hyperglycemic effect, they also have very beneficial effect on reducing body weight. If there's something new in pipeline, or if there are some new medications that maybe can do even better than semaglutide and liraglutide of 3 milligrams, I think so that it will be such a drug. This is tirzepatide. It is the dual glucose-dependent insulinotropic polypeptide and GLP-1 receptor agonist. And here you can see the results of the trial that compares compare the effect of tirzepatide with semaglutide on body weight reduction. And here we can see that with the maximum dose of tirzepatide of 15 milligrams, the patients can lose weight even double than with semaglutide, so more than 11 kilograms in comparison with initial weight. So I think so that this will be a potential drug for weight loss in patients with type 2 diabetes. And finally, what about the third option in treatment for obesity in type 2 diabetes, metabolic surgery? I think so that there are a lot of evidence that support the beneficial effect of metabolic surgery in patients with type 2 diabetes. This is one study that compares the effectiveness of metabolic treatment and different types of metabolic surgery in the rate of remission of type 2 diabetes. And we can see that after 2 years, diabetes remission had occurred in no patients in the medical treatment group versus 75 or 95% in group with gastric bypass and biliopancreatic diversion consecutively. So this is also another trial that also evaluate the long-term effect of metabolic surgery on type 2 diabetes remission, and there is a comparison of different metabolic surgery, different techniques of metabolic surgery, and here we can see that there is quite beneficial short and long-term diabetes remission in the groups, treated especially with gastric bypass. And in this group, we can see that 1 in 4 patients was in remission after metabolic surgery and 1 in 5 in relapses, which really confirms that this treatment is quite effective in weight reduction. And this is the newest study. It's published at the beginning of this year. And this is the study which evaluated the metabolic surgery versus conventional medical treatment in patients with type 2 diabetes, but with 10-year follow-up. This is the longest period of follow-up. And this study shows that of all patients who were surgically treated, 37.5% maintained diabetes remission through this period of 10 years. And what is even more important, in individuals with relapse, they were able to maintain adequate glycemic control at 10 years with mean hemoglobin A1C of 6.7%. And finally, this is the proof that the metabolic surgery is safe. It can lead to remission of type 2 diabetes, but it is very important to identify the patients who will have the maximum benefit of this surgery in order to reduce diabetic-related complications. So finally, if we want to offer to our patient some medication which is the best treatment for type 2 diabetes, that will be the medication which can reduce hemoglobin A1C, which can lead to at least 5 to 10% decrease in body weight, which can reduce blood pressure, which can lower triglycerides, raise HDL cholesterol, which is renal protective, which can improve sleep apnea, which can improve mobility, to decrease pain, and to improve quality of life. We do not have the drug with all these qualities, but that's why this is really a therapeutic profile of weight loss in patients with type 2 diabetes. So thank you for your attention.